right, guys, we have a pretty small group, but thank you for coming to our Let's Chat. We are going to go around the room and start with introductions. If you want to say your name, your agency, and your role. And if you have a rock star moment to share, you can share it with us. We would love to hear it. So I will go first. My name is Sadie Crow. I am the project manager for CBCA, and I am based out of Sacramento, and I work under the Child Abuse Prevention Center. And I will pass it off to Michael.
But Sadie, what's your rock star moment?
My rock star moment is we have our next symposium planned, which I'll be speaking on later, on movement-based play therapy with an amazing therapist. And there's CE credits involved with this one. So I'm very excited. That's my rock star moment.
Great. I'm Michael Williams. I'm Policy Director at the Child Abuse Prevention Center here in Sacramento. I hope to have a rock star moment this afternoon, giving public comment at the Assembly Budget Subcommittee, especially in support of the Family Urgent Response System. And I will hand off to Celine.
Everyone, nice to be here. I'm Celine Fabiano. I'm the Assistant Director of Pathways Counseling Center at Seneca Family of Agencies in the East Bay. I don't think I've even heard the term rockstar moment, but so I guess the best I can do is I'm singing in a concert this coming weekend, the Berkeley Broadway Singers. So, and I will pass to Denise.
I'm with you, Celine, on the rock star moment. I've never, I don't feel like I have one this week. Denise Wyatt, Executive Director at the Family Healing Center Child Advocacy Center in Fresno, California. I will pass to Lucas.
Hi, everyone. Lucas Zulo, Clinical Director of the David Farber Aspire Center in Philadelphia. And I will pass it to Stephen.
Hey, thank you, Lucas, and good morning, everyone. Steve Carroll, pronounce he, him. I'm the Senior Director of Behavioral Health Services at the San Diego LGBT Community Center. And this Saturday, we have 2 youth drop-in centers, and our South Bay Youth Center actually is celebrating its 5th anniversary. And so that's pretty amazing that we opened like a year before COVID and, managed to get through COVID by providing most of the services remotely online and then resume services back in person. And, the youth centers, going stronger than it was pre-COVID. So that's pretty amazing and glad to celebrate this Saturday, our 5-year anniversary. Yeah. So I will buckhorn it to Chelsea.
Good morning, everyone. My name is Chelsea Young. I'm a clinical supervisor at the Child and Family Center in Santa Clarita, California. I am really struggling to come up with a rock star moment. Things are a little chaotic over here. But let's see, we have not had any hospitalizations this month. It's the 3rd. Dennis, have you gone?
No, I haven't. I'm Dennis Hall with Cal OES. I've been in the children's unit for 15 years, with Cal OES 18 years. I guess you would say my rock star moment is basically every day of assisting ChAT. Right. So recipients expand and preserve their capacity due to a very dynamic employment market out there. And so I am constantly assisting them with telework, reciprocity out of state, things like that. So that's basically my rock star moment. Thank you. I thought I was last, Sadie. Sorry.
No, Shannon, did you go yet?
No, I have not. Good morning, everyone. Shannon Gonzalez. I'm the Chief Operating Officer for Family Service Association, serving Riverside County in Southern California. We had a pretty good rock star moment yesterday. We kicked off April is Child Abuse Prevention Month with a flag raising ceremony at our county admin building, and we had a wonderful turnout. great support from local government and some other really kind of key people in our community, the DA's office, sheriff's office. So really bringing some really good awareness around the fact that we can prevent child abuse. So that was a pretty big moment for us. That was our second annual. And let me kick it to Micaela, which I don't think she's gone yet.
Michaela?
Yes, Micaela.
Hi, sorry, my camera is not working. I am Micaela Patron. I am the program manager for Family Service Association. I work under Shannon, and the event yesterday for child abuse prevention was incredible. So that is a shared rockstar moment for us.
I love to hear it. And then Heather let me know her mic and camera are not working right now, but we welcome you, Heather. Thank you for coming. Next up, I wanted to welcome back our symposium speaker, Dr. Lucas Zulo. So he comes to us from the David Farber Aspire Center, which is a suicide prevention specialty center. Last month, he came and spoke on an overview of the safe alternatives for teens and youth, so also known as the safety program. So by a show of hands or a heart emotion, who was able to attend or watch the recording? A couple of you. All right, so we wanted to welcome him back this month just to do any reflections, any questions you had that you wanted to discuss with him today. I know it was very broad for a 2-hour symposium, so. And
Yeah,
if you would
I
like,
do want to say that I know I covered so much information because normally Safety A, which was the first hour, is a 6-hour training followed by 3 hours of consultation calls. And the full safety model is then usually about 9 hours followed by then 6 hours of consultation calls. And we squeezed it all into 2 hours. So if there's any follow-up questions, anything I can elaborate on, happy to do so today. And Celine, I see your hand.
Yeah, I don't have a question, but I just really appreciated all that you did pack in, and especially the focus on working with caregivers, families, and just sort of your attention to their needs and how important, that's such an important part of the whole system. So I really appreciated it.
Thank you so much. I really appreciate you sharing that. Stephen, I see your hand.
Yeah, thank you, Louis. And Lucas, I echo what Celine said as well. Really appreciated the information. I think how you presented it, it was pretty clear and really helped understand the model. I do have a question, and I was trying to, when just reflecting, I was trying to think if I just did not hear this piece, but how do folks actually make it to that point where you're offering the intervention? I was wondering, are these folks who, like youth who this was maybe their first suicide attempt, or their suicidal ideation was sort of more recent, or are these youth who maybe have had multiple attempts or sort of ongoing suicidal ideation, and somehow through repeated hospitalizations, that's how a referral is made to you and your team?
Yeah, that's a really great question. So the intervention is designed to be the first interaction you have with a youth that's at risk for suicide. So I do it as our intake process. It's like day one, they get Safety A, and then if they meet criteria for the 12-week safety program, we're able to then start that. It's also very appropriate for you've maybe been working with a youth for even months or weeks, and for the very first time, they disclose suicidality. And so that would be the time to also then use the Safety A intervention and then transitioning into the longer intervention if the acuity matches that. The way that my center is designed is it's a suicide prevention specialty center. So everyone who walks through our doors has some history of suicidality. So I am doing that at that very first session. The way they reach us is actually pretty varied, is we have some people coming from the inpatient unit. We have some people coming from the emergency department. We actually have a relationship with 988 where they refer people to us. So they're able to say, hey, can you actually wait maybe just till tomorrow morning? The Aspire Center is able to see you for an assessment. Are we able to have a relationship that way? So we have varying methods of our referral pathway. But I do want to emphasize that the intervention is designed to be across different settings. So I once did an intervention training for actually a homeless shelter serving youth. And so they were working with the youth. And if they noticed a youth was at a risk for suicide, maybe screened positive, they then went into that intervention to kind of establish safety for that risk level. So I'd be more than happy to talk about the delivery and the flexibility of the intervention in other settings too.
Great, thank you. No, that was really helpful.
Of course.
I think the other piece I was curious about too is can clients or families contact you or folks on your team outside of like scheduled sessions if if there's sort of an elevation in crisis?
Yes. So because the safety model is informed by DBT, dialectical behavioral therapy, we do use the phone coaching model. And so I do provide my Google Voice number to families 7 days a week from 8 a.m. to 10 p.m. They have access to me. And that way they're able to have live in the moment phone coaching. We also do follow the DBT model. It's supposed to be like a 5-minute phone call. This is not like a half-hour phone session out of the blue. And it's designed to be crisis stabilization. It is not meant to be drop everything as a provider, or you're out to dinner with your family and suddenly I'm going to disappear for half an hour. It's designed to be like a 5-minute conversation to establish safety.
Great, thank you. I appreciate it.
And I really appreciate questions like this because you're right. I was not able to get into the details and logistics just because I was zooming through. So any questions like this, more than happy to answer.
If anyone wanted to share any techniques that you have found effective when addressing youth suicidality that you're seeing in your agencies, if you wanted to share with the group, or just any reflections. All right, well, I think that is it. If there's any last minute words for Lucas before he heads out.
Now, I just want to thank everyone for the opportunity. If you ever want to reach out, happy to shoot me an email. You can always go to our website too for additional information at asapnctsn.org. All of the information on the safety model is available there. We have webcasts, YouTube videos, articles, and you can always click on the Contact Us button to reach out for more information too.
Perfect. Thank you so much, Dr. Lucas. We really appreciate it.
Of course. Thank you for having me. Take care, everyone.
Have a wonderful day.
You too. Bye-bye.
Bye. And so for that symposium, I did drop the recording in the chat, but I also have his whole slide deck that he sent me. So if you would like that sent to your email, I can do so because it's a lot of information, a ton of slides. But shoot me your email in the chat if you would like that sent to you. All right, next up on our agenda, we have a brief OES update from Dennis, if you would like to share with an upcoming deadline for the first quarter.
Very good, thank you. All of the child abuse treatment program grants that Cal OES has extended to you, they began January 1. So we have now completed the first quarter of this new grant, the AT23. So the important thing is just to remember that on the payment, excuse me, I'm so used to payments. The performance management tool, PMT, question 1 and question 3 will be the same number. And the reason why is because It's a new grant. And we appreciate that you have clients that carry over from the previous quarter for services. However, the PMT basically is an analytical tool for the government to study how its specific authorizations of funding are being used. So that's why the first quarter is always, question one is a number and question three is the same number. In other words, we don't count the carryovers from the prior quarter. Whereas in the second, third, and fourth quarter, you will have often two different numbers because you carry over services, from the prior quarter. So the deadline for entering the EMT information is the 15th of April. And typically, everybody does it about 11 p.m. on the 14th of April. So we're asking everybody to try to do it very soon. I realize it's only the 3rd of April, but as soon as possible. It just helps us at OES have peace of mind, but also to assist you with any other issues you might have. The PMT is like a lot of other things. It reminds the subrecipient of where they stand. It's like taking stock. And that often means that they'll have a conversation with the program specialist about, well, the reason our figures are this way is because, and then the program specialist is able to help with a modification. So I realize reporting is a necessary evil, but it's also a necessary good. It has helped many people take stock and get a new fresh start. So the other thing I just wanted to stress is that, as I mentioned earlier, and I forgot to turn my camera on, was that we are in a very dynamic human resources market. And at Cal OES, we totally understand when, for example, personnel cost category is slowing down a bit. And it's a dynamic market. That's why your program specialist can really help you immensely. And I just want to say, and I don't mean this disrespectfully at all to financial officers, but I'm told often, oh, we're fine. We're fine. And then all of a sudden I get the text, we're not fine. So I'm used to jumping in there, as Shannon knows, and helping to get things adjusted. And sometimes that even involves automobiles. I have assisted many grantees with the procurement of vehicles for transporting their clients. And everything that goes along with that, including tires, maintenance, gasoline, mileage, So I just wanted to stress that, that's all. So thank you, Sadie, for reminding me to bring that PMT up today. Appreciate it. Thank you so much.
Yes, thank you for sharing.
Welcome.
The next thing we wanted to discuss is we have our May symposium coming up, but at the end of May, it's on the 30th, which is a Thursday morning. We have Dr. Robert Jason Grant, who will be speaking on movement-based play therapy interventions. So working more a little bit with the younger youth. This is his specialty. He has a private practice in Springfield, Missouri, and he is also the creator of Play Therapy, which I will drop the link in the chat so you can look at his website and what his main focuses are. But basically, this symposium is going to explore movement-based play therapy interventions. So various interventions will be explained and demonstrated with discussion of targeted therapy needs and goals and alignment with play therapy theory and approaches with research support. This is going to be a very interactive symposium since it is play, so we might be doing some role playing, getting up out of our seats and moving around. But it's very hands-on, and I hope that it will be very beneficial to many agencies. This will also, everyone that attends the whole 2 hours will be able to receive 2 CE credits as well. But I am going to drop his website in the chat so you can do a little bit more research on him. And if there's any questions that arise of like what you want specifically in the symposium, or just for me to ask him beforehand, please email me and let me know so I can reach out to him. But I'm going to drop his website in the chat. And then that will be on May 30th from 9 a.m. to 11 a.m. And let me get that. That is a good question, Celine. Let me get the answer for that. Thank you. And then that is the registration link for the Zoom. All right, and then I'm going to bring up the agenda.
I have one question, Sadie,
Yeah.
about the training.
Of course.
When you sent out the information about it before, I looked him up. It looks really interesting. It sounds like his focus is working with, or his specialty is working with neurodivergent
Yes.
clients. So is that going to be the focus of the training as well?
I did tell him that because I was trying to look for two different speakers, like one that focuses on just working with neurodivergent and then just like movement and play therapy, but they do, you know, go hand in hand a lot of the times. And so I did let him know that that was a focus that we would like to be
Okay.
spoken on. Yes.
Okay.
I'm going to share my screen. All right, so we have come to the part in Let's Chat where we really like to do some peer sharing and open discussion. I do have some discussion questions at the bottom of the screen, but also I want to leave this space open for anything that you would like to share or ask questions amongst our peers. But we would love to hear your stories or best practices on any of these. These are just questions and conversations that I've had when doing needs assessments with some agencies, but we are open to anything that you would like to talk about.
Can I ask Dennis a question before we go into the
course.
peer discussion?
Yeah.
Sure.
Hi, Dennis. Thanks for being here. My question, we're still waiting for our, I think it's called like the award announcement or the award letter. So, so I'm assuming we can't bill until we get that. Is that right? We can't invoice?
Correct, because it's the state controller's office. You know, they are the clearinghouse for the funding. So everything has to be in award with the state controller's office before you can submit a request for reimbursement. I don't know, being that it's April, I don't know what the holdup is. I'm sorry. I'm not your program specialist, but sorry. I would contact your program specialist. Thank you.
Sounds good. Thanks.
And sometimes what I've noticed is, I don't know if you've checked like your spam, because sometimes the awards or the modifications get stuck in the spam.
Yeah, I had asked a little while ago,
Yeah.
and
Okay.
the response I got was that that sort of short-staffed and be patient kind of thing. So I'll reach out again, but thanks.
So I have a question that's not on here, but it came to mind during introductions. Is anybody here, so I'd said I'm going to be at the budget hearing where they're going to be talking about the Family Urgent Response System. Are any of your organizations involved in the Family Urgent Response System? I'd love to get stories if so. And also the Supervised Independent Living Program is another one.
Michael, I don't have any information, but I know Seneca, and it's not through chat or, but Seneca does have has some FERS programs. Yeah.
Okay.
I could see see if there's someone I could put in touch with you.
Sure. I know, and they're the Alliance for Child and Family Services is kind of out front on this, and Seneca's pretty active with them. So
Okay.
that's
Okay.
good to know.
I just want to make a comment about the group questions. Quite some time ago, Sadie, you asked me about parent-child interaction, and I emailed you back basically our guidelines that it has to not involve an offending parent.
Yes, of
So,
course, of course.
but anybody with chat can contact the program specialist, and they'll have the information about the criteria in terms of how to do that.
Yeah, I think, yeah, that's definitely a must. I think I was more curious because people are like, how are we getting the parents involved? Because sometimes they're just a little quiet and they're not so interactive. And so we wanted to see like, what best practices are you sharing or like doing, what's working for this interaction and this therapy? If anyone's had any experience with it.
Ooh, my microphone's working now. This is
Mhm.
Heather.
Hi, Heather.
So I haven't done parent-child interaction therapy in a little while just because I've been very busy. But I think that a very important part of the treatment protocol for parent-child interaction therapy is setting up the expectations of that intervention, because parent interaction is absolutely necessary for that treatment modality to be effective. And so being very clear about the expectations, about the time commitment, practicing the homework, that's all very significant in the initial stage of treatment.
Thank you for sharing, Heather. So next question is, how does your agency refer clients to other resources? I know some of the ones I've been speaking to, it's one thing to give therapy to the children, but sometimes they just need more help with outside resources that can really help their family as a unit. And they don't know where to go within their counties. And so does your agencies do anything specific, or do you have someone that refers them out?
For family service, part of our essential intake process really starts with more of a kind of a case management component where we really are kind of assessing the whole needs of the family, including the non-offending parents. So it's really kind of an assessment of, we know that a lot of our families have additional needs, and sometimes it's a whole host of needs. And we have a pretty robust internal resource guide, if you will, and partners in our community who we are regularly referring to. And if we don't have it, we do have some pretty good systems here in Southern California in regards to 211 and some other resources. IHP has a pretty good service for a referral process. So it's kind of, we really kind of head it on in the intake process. So we can really try to, as we start treatment, we are meeting those basic needs if they have those as well, and trying to prevent any barriers for successful treatment of our victims.
Shannon, Stephen?
Yeah, thank you, Sadie. I mentioned we have two youth centers, and so we really kind of try to create that continuum as well to have our youth have a safe space. And within both our youth centers, we have what we call an expressions closet. So we get a lot of donations of clothes. And so, youth, can, take what they want, take what they need. The other thing is the youth centers, we typically provide snacks during the day, but when we reopened our youth centers after COVID, we're noticing too that youth seem to take more food, on a Friday. And so just through conversations, and we more recently just kind of did a survey around food security and insecurity with youth that we work with. And so now we also have like dry goods and other things that they can take with them. Because one of the things, that we learned was that, sometimes families don't have enough food, to get through the weekend. And so we partner with our local food bank so that we do have food on hand, and again, trying to normalize it and allow youth, to take, some groceries with them on the weekend, if it's, in addition to themselves for their families. And then, we have longstanding partnerships with some of our local federally qualified health centers. And so to the best of our ability, we try to do warm handoff or connections with them for maybe folks who need to enroll in Medi-Cal or CalFresh, or just have access, to healthcare, either through mobile clinics or, through our federally qualified health centers. So those are some of the things we do. We try to provide some resources on site that we're able, around basic needs. And then for other resources, we really try to work closely with our federally qualified health center partners.
That is really great. Thank you so much for sharing.
Yeah.
Does anyone want to speak on anything else you are seeing within your agencies? Or any ideas that you want to bounce off of each other? I do want to give an update and say that our website was down for a period of time, but it is back up and we are wanting to do a lot more with it. So we've been speaking about wanting to put, resources, sharing what other agencies are doing, like a highlight section. I have been getting feedback that we definitely want a training page. So like a page that has the required trainings that each clinician has to do. And so having all those recordings, any resources for those. So we will be doing that. But is there anything else that you would like to see on our website that you feel would be helpful?
Sadie, I don't know if this could be helpful, but in terms of like resources, I'm curious. I have a couple of open positions right now. And I think we've kind of touched on this before, just curious if maybe for providers, there was a list of even some like paid job sites. I know, our agency, trying to be intentional in recruiting, a diverse set of candidates. But I think that could be helpful, to folks is, particularly if folks have the ability, to do some recruiting on paid job sites, ones that really maybe have a broader reach, or focus on diversity, in terms of just recruiting clients. So or recruiting candidates. That was something that I was thinking of.
Okay. No, that's a good idea. Thank you. Any other thoughts or ideas? Okay, guys, well, I wanted to thank you for coming today and spending your morning with me. And if you ever need any technical assistance or any resources, please feel free to reach out to me. I will be emailing the ones that want the slide deck from the last symposium. But if you have any other questions, please let me know.
Thanks, Sadie.
Thank you, everyone.
Thank
Thank
you.
you,
Have a
Sadie.
wonderful
Thank you,
rest of your
everybody.
week.
Thanks, Sadie.
Bye-bye.
Sadie, can you tell me what I missed when I had to step away?
We were just talking about the referring clients to resources like food banks and
Yeah.
Medi-Cal. And then what updates we would like to our website now that it is back up and running.
Okay. Yeah, and we have Fresno State interns from the criminology department that come in every semester. So we always have them looking up new resources. We have a resource binder. So that when families are in need, we can go through our binder and kind of see like what resources, which ones are accepting Medi-Cal, which ones are accepting private insurance. Especially in the mental health field, we don't have a lot of psychiatrists in our area for children as the CAC here. And so being able to have the information for families, the ones that are looking for how to apply for Medi-Cal and stuff like that. We have a newer center here. It's a newer medical facilities. They're called United Health Centers. They actually help families apply for Medi-Cal, and they have medical, dental, vision, all in one, kind of like a Kaiser. So I have connections with them, and we have folders that we can hand out to families as a resource for them to get started that way.
And you said you're in the Fresno area?
Yes.
That is great. I wish more counties could do that because I've just been getting that question over and over. Like, how do we get all this information?
Yeah, and I think the best thing is to utilize those interns that need to have that 120 hours for their college course, depending on the courses that they're in. So ours are criminology with the emphasis of victimology. So we're connected with Fresno State victimology. And we get them every semester. They do 120 hours. When we're short on things for them to do, we're like, look for all the resources in our county, because the Fresno County is big. It's 1 million people. To see what's available for our families when we're doing outreach, looking and reconnecting with other resource booths, like what services do you provide, so then they become a resource for us, so that we can then in turn refer families and clients to them.
Wow, thank you so
A
much.
lot of networking. But definitely utilizing our interns as well, because there's not a lot as the CAC that we can allow them to do with open cases.
Yes.
So these are the things that we supplement, like scanning some of the things and putting old cases in databases and being able to use them to research stuff.
Yeah.
Yeah. So that's what we do.
Oh, thank you for sharing that. Wow, thank you, Denise.
Thank you. Sorry I missed it.
No, you're totally fine.
But I wanted to make sure I didn't miss anything else.
Yeah. No,
So thank you.
Do you have any other questions for me?
Just the PCIT piece. Is that for your clinicians that are doing PCIT under the ChAT grant? Was that your question? Like, how does that work for them? What were our thoughts on that?
The PCIT.
The parent-child interaction therapy.
Oh, yeah. So basically, I've been doing needs assessments with every agency, and they're just saying, like, because it's fairly new for them under this grant, they're struggling with the parents being very involved with it.
It is extensive. I myself had to do PCIT with my son, who's autistic.
Okay.
So as somebody who's done it and had to make the commitment of taking time off of work to sit with them for an hour, possibly an hour and a half, really disconnect myself from everything else except him. It is intensive. We did, I want to say 6 to 8 weeks of it. So that's a commitment that a lot of parents aren't willing to put in. Especially when we have mental health at no cost to them, and they're not willing to even put into that to bring their child into the center. We've been able to utilize more of our services for mental health because of Zoom, but you know, if it's inconvenient for the parent, most times they're not gonna want to do it.
I didn't even think of that side of that piece because I used to do direct services and work with children with autism, but the parent had to be there too. And that's 2-3 hours out of their day every other day, you know, if it's
Right.
extensive. So I
Yeah.
didn't think of that piece of like, you have to put everything else aside too, and you still have to
Yeah.
work and make a living. And
Yeah. It's a commitment, and that's why, you know, for me it wasn't a choice. Like, I knew this is what I had to do for my son when, you know, years ago when he was little. But that was the choice that I made. And so I knew how important it was for both of us, especially with behavior problems with him being autistic. So again, we see the need for PCIT. I think it's amazing. I loved it. We developed a stronger bond because of it. But for some parents who aren't as involved with their children, especially, you know, depending on the situation, it's a little difficult.
yeah, that makes sense. Thank you. I really appreciate you coming and
Yeah.
sharing your thoughts and being a voice.
Thank you. Thank you. I'll see